Good afternoon and welcome to United TV. My name is Kemal Erkan. Today is our Bariatric Friday session with risk and complications of bariatric surgery. And we are starting a little bit earlier than our 3 p.m. time. And today, with some of the travel scheduling, we are making some adjustments. And then our 2 p.m. session, normally that happens, is going to happen at 3 p.m. as a premiere. And we still wanted to have our Bariatric Friday in as a live session, and Dr. Irgau was nice enough to make changes on his schedule, and he's here with us. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Of course, I wouldn't miss the Bariatric Friday.
So this is actually kind of with this cycle that we are going through, when there are certain sections that we can kind of complete. That's important for what we are doing. And then I know we are going to have 2 weeks for the premiere break, and then we'll be back with the live sessions as of third week of February. So today we are going to discuss the risk and complications of bariatric surgery. Now, this is something that you do on a regular basis when you see the patients first at the consult, and then as you see the patients throughout the process, and also from our other multi-specialty discipline providers. This may be cardiology, bariatrician, this psych, and all those, when they're all added together. So we are kind of completing all the risk and complication potential issues with the patient. And our goal for today is to give another avenue for those patients to kind of better understand what it is in terms of short-term and long-term, and how we can actually mitigate these issues, and what would be the first plan of action when these emergencies happens. So I would like to start with the first question. What are the most common short-term risks following bariatric surgery, and how often do we encounter them?
Of course. Well, I will answer the second question first. How often do we encounter them? Not commonly. Okay, complications can happen like in any surgery, of course, but with bariatric surgery, the way it is currently set up, particularly in centers like ours that are accredited centers of excellence, the quality and safety of bariatric surgery is extremely high. Nevertheless, it is surgery, and as surgeons, we know that in any type of surgery that we perform, the potential for complications is always there. The question is, what's the best way to deal with the complications, and how do you actually deal with them? And that's a very important topic for us as well. In terms of what are the most common early complications of bariatric surgery, it is probably useful to talk about the more serious types of complications. And those would be three. One would be infection caused by a portion of the stomach or intestine that fails to heal properly. It's something that we call leak. Another potentially serious complication is the formation of blood clots, either in the legs, the lungs, or even in the intestines. The third potentially serious complication that can occur early is bleeding. Now, these are potentially serious complications, and of course, they can be life-threatening as well. But the good news is, as I said earlier on, these are extremely rare. More importantly, we do have excellent methods for prevention, and so that's why we don't see much of these complications. But also we have excellent approaches of rescuing, patients who do encounter these complications, for us to be able to take care of them in a timely fashion, so that patients can safely navigate out of the complications.
So most of the complication does happen in the short term anyway, right? So we understand that.
Yes. So yes.
We know this right away.
Yes.
In many cases.
Yeah.
So, and then second, kind of like a short term, the next level short term is within 30 days. And then after that, usually we don't see anything At least I don't hear much from what we are doing.
Right.
And that's kind of true for probably other programs as well.
Yes, absolutely. So just looking at these three potential complications that can happen either with the gastric sleeve, the gastric bypass mainly, but they can obviously happen with the lap band and of course with revision surgery as well. So just to give you an idea of the time frame, right? So of the three potential complications, the infection due to leaks, the blood clots, and the bleeding, the one that can happen most at the earliest time would actually be bleeding. Bleeding can be seen, in fact, it is usually seen within hours of surgery. Mm-hmm. That's why, as you know, in our surgery center, the most intensive monitoring time is actually the early hours after surgery by having the patients being on a monitor where they're looking at their heart rate, mm-hmm. we're looking at their blood pressure, we're looking at their oxygenation very, very frequently, okay? Like all the other complications, the best way to deal with this complication is to prevent it in the first place, right? And that's where we focus on prevention of all the factors that could increase the potential for bleeding, whether it is the timing and administration of blood thinning medication, for instance. Mm-hmm. All our patients get a blood thinning medication. Why do they get that? Because we want to prevent blood clots. But when you give somebody a blood thinning medication, you increase their risk of bleeding. So where we focus is the timing of the administration of that blood thinning medication is critical because mm-hmm. there is going to be a time where the level of that medication is fairly high and the risk of bleeding is higher at that time. Mm-hmm. Right. So we focus on that timing importantly. Secondly, we try not to give additional medications that could increase the risk of blood thinning, or we time them in a way that there is no overlap between these two medications. Sure. And then finally, of course, as I said, because it can happen early after surgery, we are monitoring the patients very closely for any potential signs of bleeding. The other complication, for instance, blood clots, generally blood clots tend to occur if they do within 2 to 4 weeks after surgery. Okay, so there is a more extended period of time. There are the best.
Is that because of the patient compliance with the medication? Is that kind of the issue?
Well, it is a number of factors. So blood clots generally can occur after any type of surgery, mm-hmm. which means that surgery by itself, the administration of anesthesia and performance of surgery, mm-hmm. particularly certain types of surgery, puts the patient at a higher risk for blood clots. But there are other factors that mm-hmm. can increase this risk. For instance, patients who have a very high body mass index would have a higher risk. Patients who've had a history of previous blood clots would have a higher risk. Patients who are above the age of 40 will have a higher risk than younger patients. And patients who are not as mobile, for instance, if they are on a wheelchair, they cannot walk too much after surgery, they will be at higher risk. Patients who have had a history of some types of cancers would have higher risks. All these are important factors that we put into consideration when we apply preventative measures, right? And as you know, the preventative measures, the most important for us is to get the patient up and walking early after surgery and for them to continue to do so during their recovery. And we do this very, very well, and it's based on education. But the other thing we do, Kemal, is we provide compression stockings around the legs of the patients mm-hmm. that are actually dynamic. They compress the calves of the patient so that blood circulation from the legs is increased. And it happens despite the fact that the patient is immobile because of the anesthesia. So those help us greatly. And then the other thing we do additionally is, as I said, we mm-hmm. administer a blood thinning medication, which, you know, surgeons in the past, when we were doing these open surgeries, we dreaded the idea of giving a patient a blood thinning medication before surgery. But mm-hmm. now we can do it comfortably because of the advancement in technology that allowed us to do surgery through very small incisions and with a lot of precision. And how about leakage infection? Well, that can actually occur usually between the 2nd and the 6th week after surgery. Mm-hmm. That's the time frame that it can occur. And so, again, we pay a lot of attention to factors that could increase this. For instance, gastric sleeve is the one where leaks can happen a little bit more commonly than gastric bypass, for instance. And why is that? Well, because the stomach is so small and narrow that the pressure inside the stomach rises considerably, putting a strain on the suture line of the stomach. So reinforcing that suture line with additional material, as you know, the Surgery Center provides this for us, is very important. But more importantly, also understanding the geometry of the sleeve so that there is no increased points of pressure on the stomach is very important. All those are very critical factors to minimize the risk, but it can still happen for a number of other reasons, right? So what do? We educate our patients for them to come back and tell us if there are any potential signs of an infection. In fact, the standard education we give our patients is that after they leave our center, they should continue to progress in their recovery. If they feel they are going backwards, like having pain more than they've had the day before, having nausea, vomiting, or fever, all these are signs that should alert them to call us so that we can look into it in a timely fashion and so we can address this issue. So to summarize, bleeding can happen within hours. Blood clots can happen between the 2nd and 4th week. Most commonly, an infection is caused by leak usually will happen between the 2nd and 6th week after.
So our percentages for these are in like 1 in thousands, 1 in 1,500.
Very low.
So
very low. Very
we
low.
don't see them very often. So it's one of the reasons when we talk about these risks and complications, if there was like an ongoing issue, but we don't. So now, one of the reasons it doesn't happen also, as you were explaining from the patient education process, but also our patient screening process is probably one of the best in the country in terms of the bariatric.
Yeah.
And it's kind of interesting. I don't know if you felt the same way when we were going through some interviews with some new surgeons. I can see how they were kind of shocked. And these guys are coming from good programs.
Yeah.
And what we do on a day-to-day basis with the case conferences and just taking the patient from the consult to the surgery, then having their follow-up appointments in the same program. So it just doesn't happen in every other program. And then that's probably why we're also having a better outcome with these. And, you know, it just like anything, it just comes down to the prevention.
Yes.
And then that prevention is, in this case, either the clinical team needs to do certain things, like our database helps us to flag any and every other issue that we may see. And sometimes like you can probably attest to this. So I asked the same question, even I know the answer, just to make sure that I get the same answer. So that because in one thing that we don't want to make any assumptions, as you always say in the clinical setting, the duplicate.
Additional levels of redundancy.
Duplicate redundancy is one of the good things in clinical settings.
Absolutely.
So it may not be so efficient in other settings, but this is where we need that. And therefore, that also helps our patients' outcome as well.
Absolutely.
Now, I want to talk about the nutritional deficiencies and kind of like overall explaining to those who are going through the process, what are the nutritional deficiency and is it like long-term and what can they do to address those concerns ahead of time?
Absolutely. So essentially, one of the ways in which bariatric surgery works is by decreasing the amount of food the patient consumes, right? Because that will lead to a direct decrease in the caloric intake as well, right? But when we are interfering with the patient's ability not only to eat food, but also to process that food by making changes in the digestive tract, yes, we are succeeding in decreasing their caloric intake, but we may be interfering with the patient's ability to take in absolutely necessary nutrients, the so-called micronutrients. And these are clearly vitamins and minerals. Now, this is much more pronounced with procedures where there is intestinal diversion or intestinal bypass, like the gastric bypass or the duodenal switch. It is less significant, less impactful rather, with a procedure like the sleeve gastrectomy, where there is only interference with the stomach and not with the intestine, and of course, even less so with the lap band. So what we have to do is we have to educate our patients about this fact that will become a reality in their post-surgical life, right? And we also educate them of ways to minimize its occurrence or avoidance of this problem totally, right?
Mm.
And this is based on getting them to do two things. One is to make sure that they have multivitamins and minerals appropriately on top of what they're eating. So all our patients will have multivitamins, but some patients may even need additional specific vitamins, like, for instance, vitamin B12 or folate or vitamin D, particularly patients who've had intestinal bypass surgery. The second thing we want them to understand is that they need to follow up with us or their primary care with respect to checking for these deficiencies, which means they have to have blood tests done periodically. It doesn't have to be every month, but in the long term, they should have blood tests done at least once a year, if not twice a year, and then address deficiencies that are reported on that blood work. And this commonly will show, for instance, vitamin D deficiency. Sometimes we will see B12 deficiency. Sometimes we will see B1 deficiency. I saw a patient today who had a vitamin A deficiency. So all these need to be recognized and addressed, and they can be prevented as well by having the patients become compliant with the intake of vitamins and micronutrients as they have been taught by our nutritionists, right? Another important factor, of course, is to understand also that if they focus on foods that are rich on these micronutrients, then there is going to be less likelihood of deficiency. Right. If they're going to focus, for instance, on processed food, on so-called junk food, or food that has a long shelf life, for instance, as opposed to freshly gathered food, then they are going to be at risk of deficiency. So these are the things we do. But also the other important thing to understand is we're not just worried about seeing the deficiency in the blood work, right? The deficiency in the blood work is obviously information, but what is the consequence of that deficiency? Well, if that deficiency is not addressed, the consequences could be even severe. They could lead to hair loss. They could lead to poor healing if there is a wound. They could lead to weakening of bones or even to permanent nerve damage with certain vitamins. So it is very important that patients understand that, are well educated and versed on this, and then follow our recommendations to really avoid and prevent these deficiencies.
Now, with the nutritional deficiency, the other thing that I can think of is the weight regain. So that's kind of like the fear for many patients. And we have seen that not every patient or not everyone is going to go through the same process. And how do we know this? Is just even outside of the bariatric program, I know from our accountable care side where even like the diabetes and hypertension medications are not being filled on a timely manner, while they're actually having those. If they're not maybe at the morbid obesity level, but they are dealing with obesity itself and hypertension, they don't have a nutritionist support. So, the full management of the disease is left to the medication only. And I think patients are kind of at fault on this as much as everyone else, because when the orders are given, we feel like sometimes there's no benefit, but that's a huge mistake. Now, what are the things that patients can do to prevent the weight regain after the surgery? How can we address that?
Yeah, this is actually one of the toughest issues that patients find hard to come to terms with, and that is to really accept that obesity can defy even surgery. But this is the truth, right? Surgery is actually extremely powerful in its ability to take care of obesity, but it's not a magic answer, right? So, and this is really the cornerstone of our teaching, and that is patients not only they have to change their lifestyle, but that change has to be permanent, right? So eating healthy foods, being active cannot be optional things after bariatric surgery. They are really mandatory for patients to be successful in the long term. Even the most radical surgeries that we do are not immune from this issue, Kemal. Weight regain can happen. The good thing is that the struggle with weight is not going to be the same struggle that they've had before they've had surgery, because now with the surgery, they have a powerful tool that can give them really the success that they're looking for. Mm-hmm. But what do they need to do is, first of all, realize that the surgery is a tool. And they cannot forget that the tendency for their body to push for a higher weight is really encrypted in their biology. And the surgery is not changing that inscription, right? Mm-hmm. It's providing them a tool. Once they understand that and they commit to those changes for life, they will be fine. Mm-hmm. You know, we've been doing bariatric surgery now for over 20 years. And one of the most gratifying things we see, Kemal, is to see patients that we've operated on in their late 20s or early 30s, and now we see them almost in their 50s, or patients we've operated in their 40s, and now they are in their 60s, healthy, no high blood pressure, no diabetes, with a very healthy body mass index and healthy weight. Mm-hmm. They've been able to maintain that. So, and why these patients were able to maintain that? Because they followed everything that we tell them. And it's no surprise that when you sit and talk to them, they will tell you that for all these decades, they have been following exactly what they were taught at the beginning. And that's why they are able to manage their success. But to follow these instructions now, they're not making too much effort, Kemal. It's not like they're struggling every day, mm-hmm. right? Because the tool is still there. They still know that if they overeat, they will feel it, right? So the tool is working, their commitment is there, so the success is guaranteed, essentially. Now, when you have the tool, but there is no commitment, there is no change, then obviously the potential for weight regain is still there.
Well, when I'm listening to you, just, you know, like we have certain things we kind of prep for these, but then every time I'm listening, I can't help but think about stuff that's happening throughout the day and the week with me. And, you know, how one week is different than the other. And it has a lot to do with the compliance of the person. I'm not going to say patient in this case, but the person. So this week, you know, I did my intermittent fasting. Mm-hmm. Only one day I had a bad lunch, but the rest of the time, my breaking meal was raw bar. Okay. And I used to do 2 raw bars mm-hmm. for that, mm-hmm. just to kind of see, because I didn't want to be hungry again. So then until dinner time. Yep. So in the last 3 weeks, the 1 raw bar is more than enough. Mm. That's what I kind of see these days. So, yep. And then this week when I did it properly without a lot of, you know, fast food or junk food, and you just feel it. Just you just, like, from the clothes that you are wearing, the people are making notices. And the point that I'm trying to make is the patient compliance is extremely important. Commitment is extremely important. However, we know that this is not going to happen for everyone again. Mm-hmm, mm-hmm, and we are mm-hmm. also guilty, just like, you know, okay, I'm not going to say this. So, now, here's my issue. Mm-hmm. If the patients, you know how we are kind of judgmental as a society for the morbid obesity mm-hmm. part of the chronic illness of morbid obesity, mm-hmm. we have a problem with, mm-hmm. like, not we, but the society, mm-hmm. that we are still educating them. Yep. And I think 10 years from now, they're going to say, hey, those 2 guys were talking and then doing a lot of stuff, so they were so right. So, and then we see it again with some, you know, we haven't done a lot of interviews, and then those interviews are kind of helpful in some ways when they actually watch some of our sessions, and they're like, hey, actually everyone should be watching it, yeah. even in medical school and residency and fellowship. And I agree with them because, I mean, you are here. So, I mean, not every program has the bariatric surgeon available every time. So right. People don't understand this. So how difficult to get someone here yep. Who is already busy. Now, mm-hmm. my issue is kind of addressing these revisional surgeries. Mm-hmm. So failing is okay. So, I mean, we are not saying that you should fail, but just like, someone who has diabetes and they try different medications, they have side effects, and they cannot use, for example, metformin. So they have to use something else. They cannot use insulin. They have to go with different options, but they have to try and find what's right for them. And the failures and then finding new solutions is just the norm in those managements of other chronic illnesses. When it comes to morbid obesity and bariatric surgery, just like if someone who had gastric band 15 years ago, for that patient to, if they have the problem with the weight gain, it's just totally fine for them to come back and then look for the options on the revisional surgery. Can we actually just talk about what those options are and what you see from those patients? Do you get any negative feedbacks, or if they feel kind of like they failed and now they are coming into a different surgery? How is that working?
Well, our view on what bariatric surgery is no different from any type of surgery that is directed at treating a disease, right? So if there is a cancer, right, and we do surgery to fix it, and if the cancer comes back, we have to fix it again, right?
Right.
We don't say, okay, we've done one surgery and then that's enough. We don't say that, right? We treat the disease. It is the same when we treat obesity as well. So as bariatric surgeons, we have tools available to us to help patients when patients struggle. And the struggles with weight regain or with inability to lose enough weight are multifactorial, right? Yes, of course, often there may be the fact that the patient is not committed, but it could be a patient whose metabolism is so very, very resistant that, that surgery is just not doing it for them. They need additional surgery. So if they've had a sleeve, maybe they need a gastric bypass. If they've had a sleeve, maybe they need a duodenal switch. And we should not be having any issues about offering these options and see if those apply to the patient, because it is important for us to be there to offer them, right? Now, surgery or repeat surgery, or as we call it, revision surgery, may not always be necessary. Sometimes other measures may do, right? For instance, redirecting that person to a certain diet, or if they're struggling because of stress, because of emotional issues, getting them to a counselor. Do what we call a reset diet, sometimes by putting them back in that liver shrinking diet that we do before surgery. And, or exploring the potential for weight loss medications. All those are available.
Right.
Things that we should be able to provide to our patients when they are struggling. That should be part of what we do, and that is part of what we do. And then in appropriate circumstances, we provide revision surgery as well. Now, the most common revision surgery that we do, as you know, Kemal, is converting a lap band to a sleeve or to a gastric bypass.
Right.
And that's because of all the three procedures, probably the lap band is the weaker procedure when it comes to sustainable weight loss in the long term. So it's no surprise that we are removing gastric bands and then going to gastric sleeve or to gastric bypass. But we've had situations in which we revise a sleeve into a gastric bypass as well. And now the reason could be because there was weight gain, but also there may be issues like heartburn, for instance, which can happen after a gastric sleeve, in which case switching the gastric sleeve to a gastric bypass will offer benefits from that perspective as well. Now, when we offer revision surgery, we don't offer it lightly. It is obviously repeat surgery, and repeat surgery does carry a potential for higher complication rates. And the reason for that is because we are working on tissue that is no longer virgin. That tissue has been worked on already with previous surgery, so its healing capacity is being interfered with, right? And that can lead to more complications. But even with revision surgery, we have a very high rate of safety profile because we're very experienced with doing the surgery as well. So our complication rate, even for revision surgery, is actually fairly low.
Sure. And I think we kind of covered the main issues on the risk and complications, and part of the Bariatric Friday is designed to address these complications and issues in different topics, and every week that's what we are trying to do. Now, one last thing that I would like to say is our patient selection process and the education. Again, that is probably the state-of-the-art system that we have and the clinicians we have. So we are supporting whatever we do on the clinical side with the with our IT and database utilization. These are custom database that's specific to the bariatric surgery flow. And from day one, we know whether or not this patient is the right candidate for the surgery. So, and there's a designated person, designated nurse who they are able to talk and then help get help for their appointments. And then this is what also we do now in the last 4 years. It's one of the verified channels that's now, so many videos available for those for more education. So I would like everyone to take advantage of what's out there for them. And then we'll be back with, different topics that we are going to cover. But anything that you would like to add before we close today?
No, I mean, I think this is an important topic for us to address. This is one of the topics that really creates the most anxiety when patients are looking into surgery, and that's very natural. It's very normal to feel anxious before surgery because of the unknown, but the more patients learn about how we really we prevent complications and how we take care of them if they happen, the more comfortable they will be, particularly when they focus on the benefits of the surgery.
Absolutely. Well, Dr. Ergau, thank you so much for joining us today, and then thank you for being flexible with the time. So we'll be back next week with another topic on the Premier side, and then the third week of February we'll be live again. So please stay safe, and we'll see you soon. Thank you for watching.
Thank you.